Hello everyone, this is Kitty Clinical, and today we're going to be talking about the Wells criteria for DVTs, not to be confused with the Wells criteria for pulmonary embolism. They are different criteria, and the big thing to know about the Wells criteria for DVT is that the Wells score is less useful in hospitalized patients, according to a 2015 paper from Silveria, and I will link that in the description. And that there are different versions of this criteria with minor differences. I will be focusing on the one that is on MD Calc because that is the one that I have pulled up. And it is an important thing to know, as far as what to do, how to manage DVT, how to assess, risk stratify, all this stuff, and what the management. So we're going to do kind of the same thing we did for the Wells criteria for pulmonary embolism. I'm going to talk about each criteria and the point system, and then we'll go from there. So the first criteria is active cancer. Are they going through treatment, or are they palliative within the last 6 months? If no, then 0. If yes, then +1. And if it's no, it's 0 for everything. If they're bedridden recently for greater than 3 days or major surgery within the 12 weeks, yes, +1. Is there calf swelling? More importantly, is there calf swelling greater than 3 centimeters compared to the other leg, which in this case you'd measure 10 centimeters below the tibial tuberosity? You get a point for that if that is a yes. Is there collateral or non-varicose superficial veins present? That gives you a point. Is the entire leg swollen? That gives you a point. Is there localized tenderness along the deep venous system? If yes, that gives you a point. Is there pitting edema confined to the symptomatic leg? If yes, that gives you a point. Paralysis, paresis, or recent plaster immobilization of the lower extremity, that gives you 1 point as well. And has there been a previously documented DVT? That will also give you a point. More importantly, is there an alternative diagnosis to DVT as likely or more likely? That gives you -2 points. So if you can explain these symptoms from something else and it's likely or more likely than the DVT, then subtract 2 points to your score, and that will give you your score. So as with all clinical decision aids, the criteria is meant to aid clinical decision making and not to force management. And I would make the argument that that's true of the other, the Wells criteria for the pulmonary embolism as well. You never want to, you're the doctor. You're the one that makes the decision, right? It's all dependent on you and you only. The person's life is at your stake here, right? And again, you should apply these criteria only after a detailed history and physical exam. Should only be applied to those patients who have been deemed at risk for DVT. If you're not concerned about a DVT, then there's no need to risk stratify or do any of this stuff. Okay, that's those are the recommendations here, and we divide them into 2 categories: DVT unlikely and DVT likely groups based on the Wells score, and then additionally, moderate risk group can be added based on the sensitivity of the D-dimer being used. So if your score is 0 or lower, that's associated with DVT being unlikely, obviously. Prevalence of DVT is only 5%. You can proceed with D-dimer testing if you want. Negative, higher, moderate sensitivity D-dimer results in a probability less than 1%, and no further imaging is required. If you score positive, then you should proceed with ultrasound testing. Now, keep in mind that D-dimer is sensitive, but it's not specific, right? You're ordering a D-dimer to screen, and it's not necessarily just because your D-dimer is high. It doesn't mean you have a DVT, right? You could have whole sorts of other things. And once you go through ultrasound testing, negative ultrasound is sufficient for DVT rule out, but a positive, you want to consider treatment with anticoagulation. If you score a 1 to 2, then your pretest probability jumps up to 17%. And you should undergo high sensitivity D-dimer testing. Moderate sensitivity D-dimer is not sufficient. Negative high sensitivity D-dimer is sufficient to rule out DVT in a moderate risk patient with a probability of less than 1%. A positive high sensitivity D-dimer should proceed to ultrasound testing, and a negative ultrasound is sufficient for ruling out DVT. A positive ultrasound is concerning for DVT. Strongly consider treatment with anticoagulation. Score of 3 or higher suggests DVT is likely, and the pretest probability is anywhere from 17 to 53%. All DVT likely patients should receive ultrasound. D-dimer testing should be utilized to help risk stratify these DVT likely patients. And in DVT likely patients with negative D-dimer, a negative ultrasound is sufficient for ruling out DVT. You can consider discharging them. A positive ultrasound should be concerning for DVT. Strongly consider treatment with anticoagulation. And in DVT likely patients with a positive D-dimer, a positive ultrasound should be concerning for DVT. You treat with anticoagulation. Negative ultrasound still concerning for DVT. Repeat ultrasound should be performed within 1 week for reevaluation. And groups should only undergo D-dimer testing for rule out without ultrasonography if a high sensitivity D-dimer is being used. But MD Calc makes a really interesting point here that no decision rule should trump clinical gestalt. I love that word. High suspicion for DVT should warrant imaging regardless of Wells score. The Wells criteria for DVT is utilized for the workup of DVT. The presence of DVT is critical to the evaluation of possible PE. And if PE is on the differential alternative decision aids such as the Wells PE or PERC rule should be entertained. And we can talk about the PERC rule later on. I did make a separate video on the Wells score for PE, but this test is useful. I don't often use it because I don't get a lot of DVT in the outpatient setting, but it is something that you want to be mindful of, keeping in mind that it is less useful in the inpatient setting, but it is something that you can certainly use in the outpatient setting. But just keep in mind that with this Wells criteria for DVT, it comes with caveats. That being said, that use your clinical judgment. You are the doctor, and that seems to be the big take-home message on the MD Calc evidence explanation. So, hope you enjoyed this video, folks. If you have any questions, please ask them in the comments below. And as always, like and subscribe. See you in the next video. Take care.